we have listened to two great presentations, one setting up the base for the metabolic therapy, the other one telling us what is new in the management of patients with chronic coronary syndromes. But now, going back to you all, and I would like to understand whether there are questions, there are doubts, and what do you think about the presentations? What would you hear more, and if you have any specific questions? So don't be shy and get started. Who's going to go first? So, I mean, now just to break the ice, and just show up your hands if you wish. Now, how many of you spend less than 15 minutes to see patients in clinic, especially if there is a busy clinic? So, none of you. But what we've heard from the survey is that there is a 30%, 40% of physicians who do spend less than 15 minutes. And that is, if you go in many countries where there is especially those with the universal healthcare system, then there's a limitation. The other question, how many of you do you believe that when patients go back, they go back home, they've understood what you said in terms of explaining the symptoms, explaining the medications? I can see from the face that not many of you. So I think, I think that probably we'll need to find a way of to give a better education in terms of conveying the message better. Now, I see that there is a question from Carlo Martinez. Can you speak up, please?
Yes, hello, doctors. Thank you for your great presentations. My name is Carlos Martinez from Medellin, Colombia. No, I just want to give my impression about your previous question. In our country, our outpatient consult is pretty busy. So most of the time, we don't have enough time to give to the patient. So more of the times, especially if we are in the clinic, the time to give to the patient is like 20 to 50 to 20 minutes. But when we do our private consult, maybe we can give more time for our patients, and I can see that is a big difference. And when you can give more more time to the patient and explain the medications, the implications of the treatment, most of the patients do well. So I can contrast my private practice with my hospital practice, and I can see that in the private practice, just giving more time to the patient, that makes big changes.
Yes.
Thank you.
Thank you. I think that this is very important because it also highlights that there is a different way of approaching patients. And I believe all of us share your comments. And when patients are seen in private practice, they get more time than when we see them in the National Health Service. I think that this is something that is shared by all of us. What do you think? I see everyone is nodding. I think. So, any other question? You're too shy.
Hi. Can I go ahead? Hi, Omala Black from the Bahamas. And so thank you very much for two really excellent presentations. And yes, I agree, we don't spend enough time educating patients, and there is a big difference between the private practice and the hospital practice. And so what I try to do is each time the patient comes, give them a little bit more information. And I try, like, so for example, I would say, bring all the medications to the clinic. And then I take all the boxes and I write on them, this is for your blood pressure. This is for when you have chest pain. This is for when the legs are swelling and you're short of breath and you're lying down. And so I'll do that on the first visit. And then as each visit comes along, I give them more and more information, or sometimes I just write things down for them, print it out and send them home. Sometimes they're on 2 antiplatelets. So I would put, take the clopidogrel with breakfast, take the aspirin with lunch, just to avoid complications. And I find that that does work. In most cases, patients don't understand what you've said to them the first time or the second time. So when I teach, I encourage my medical students and my juniors to give the same information every single time. And I do find that it makes a difference. And each time the patient comes, they learn a little bit more and they actually have more questions for you as well. But it's a massive challenge, the time constraints in the public sector.
No, I mean, I fully agree with you. I mean, time constraint is a problem, but I think that each of us has its own techniques, and I share what you do. I also write on the boxes, either when they have to take it or for why they're taking it, and I think that helps in many cases. Yeah, that it's a very good way. But also, I think another important message that came from you is how we need to teach the younger generations on how to convey the message to our patients. Now, any other questions from the group? I mean, please take into account that you'll be the group who will be then going to in a cascade of education to all your peers and your colleagues. So if there's anything that you believe you want to ask, I mean, don't be shy. Don't be shy. I mean, it's just we are just amongst friends, and nobody will question. So if not,
again, Omala from the Bahamas, I have a question about the trimetazidine and, understanding it works like a beta blocker, the lack of hemodynamic effect, more energy. Is this a drug that we should be considering promoting the use of in heart failure, maybe from stage 3?
So, Francisco, do you want to answer first, and then I'll follow?
Yeah, sure. There's evidence using trimetazidine in heart failure, and apparently there is not too much studies regarding that, but they are considerably enhance the effort of using, because the energy substrate that give you the trimetazidine is very concurrent with the heart failure metabolic crisis. So it's very logical to use it. Regardless, there are no many studies, but those studies show that it's a benefit, especially in the element of symptoms regarding the functional class, walking distance, and those kind of things.
Yeah. No, fully agree. I mean, our group was the first one to show the effect of trimetazidine on left ventricular function, and we and others have shown that there is an increase in contractility, an increase in exercise capacity. I mean, this data came when trimetazidine was already generic, so there was not much interest in conducting a multi-center trial. However, there are the 3 meta-analyses, one in JACC, one in Heart, and another one, I think, is in the journal, in the American Heart Journal, that they basically demonstrated that there is a suggestion of also of a survival benefit, but of course that doesn't come from randomized clinical trials. Whilst the randomized clinical trials showed the efficacy on contractility and on exercise capacity. Now, there was a question or an attempt for a question from Olympio. I cannot see fully your name. You wish to go ahead?
Yeah. Can you hear me?
Sure, yes.
Considering your survey, is one of the problems that many doctors face nowadays is the atypical presentations of angina. So they don't recognize the symptoms as real angina. And if you consider that they have a short time of consultation, they don't explore the symptoms. So, and another big issue is the atypical manifestations that we have in women. So they present with more often with atypical presentations. So if you don't take this into consideration, the level of suspicion will be lower and the diagnosis will be compromised.
Yes, no, you're entirely right, and especially the different type of presentation of chest pain. And I'll give you one example. I work in an hospital that basically drains a very wealthy population, for British population, and also drains from another ethnic minorities. So when I ask my patients with a British background on whether they get chest pain, and they say, no, I don't get chest pain. I get a little bit, a tightness in my chest. Then I get the Italians, the Spanish, the Greeks, and they said, oh, doctor, I got this crushing, terrible chest pain. I cannot bear with it. And then it gets the Southeast Asians, and they never said no. They said, no, doctor, I don't have any chest pain. I get this gas in my chest. So you see, it's important to recognize the different what patients are trying to tell us. And I think that apart from what you've highlighted very importantly, which is the difference between men and women, it's also important to understand that different genetic and cultural backgrounds are important in the way patients refer symptoms. But then probably with time we understand and we learn that what our patients want to tell us, and when we see them and we frame them, then it's we understand. And I think it's always important to ask what is the precipitating factors, what is the duration, and where is the localization, regardless. Because with these three different questions, we can exclude most of the non-cardiac pain. And I ran a clinic on angina with normal coronary arteries. I have to say that 30% of patients have a non-cardiac pain and they have to be sent away. But you can ask them just on the characteristic of the chest pain. But I fully understand with you gender differences and origin. So, want to say something more, Olympio?
Yes, I agree with you, but I think it's especially important when we try to characterize or to have a suspicion of the mechanism of angina. If there is a variable threshold of angina, if angina occurs at rest in the early hours of the late hours of the evening or early hours of the morning, so you can have a suspicion based on the characterization of the symptoms, but we have very limited resources to investigate, coronary flow reserve in terms of invasive or non-invasive methods. Of course, we know that you have evidence to that, but we don't have the evidence available in most of the centers here in Brazil. What about in England, in your center?
Oh, yes. No, we do quite a few adenosine tests and ergonovin tests. I have to say that when if you don't have that, I think one very good way of looking at it is the blushing or the slow runoff of contrast that may help. So if you have limited resources and you cannot do it because it's expensive and time consuming to do all those tests, then looking at the runoff and the blushing is one way of at least identifying those patients with some forms of microvascular angina. Now, we have a few questions on the chat, and there's one for Dr. Lopez on how we can understand the results of the Orbita 1 compared to Orbita 2, and one to Dr. Padilla regarding the use of tremetazidine in patients with different degrees of coronary obstruction, specifically in those with microvascular angina. So if we can start with Dr. Lopez and then go to Dr. Padilla.
Okay, very good question. Let's imagine the same investigators from the same center, the Imperial College of London, Orbita 1, tried to test the hypothesis that PCI was better than medication, but the patient need to have a background anti-anginal therapy, at least 3 anti-anginal drugs before going to the cath lab. So this is the first difference. Remember, Orbita 2, patients have to be out of any anti-anginal drugs for 2 weeks before going to the cath lab, okay? So that's the initial difference. The outcome of the Orbita 1 was the time spent on the treadmill test. The difference was just 16 minutes more for patients who underwent PCI. There was no statistical difference between the patients managed just with anti-anginal or with anti-anginal plus PCI. And here in the Orbita 2 trial, there was a real difference between the angina score with the difficulties of understanding this composite endpoint. Time spent on the treadmill was 59 seconds, not 16, just 59 seconds. But the rates of angina, the relief of angina, was just in 1 out of 3 patients in the PCI arm. What that means, what I already told, PCI is just another kind of therapeutic tool to improve patient symptoms. Orbita 2 just showed that a fourth anti-anginal intervention, in this case PCI, didn't work that well because patient may have an anatomy that was not suitable for that, or because the pain was caused by another cause that was different from angina. And maybe is that concept comes with real force here in the Orbita 2, because remember what happened with those 2 patients that didn't improve their angina symptoms despite being revascularized. Well, maybe that's because we're just opening a blood bed that is not really involved in the symptoms of these patients. So 2 different trials, but I think they are complementary. Orbita 1, just PCI as the 4th anti-anginal intervention, Orbita 2 as the first-line intervention.
Thank you. And Francisco, I saw that you had answered in the chat, but if you can just repeat your answer on the microvascular angina.
Sure. And I want to add something about Orbita. If you look at the data from Orbita 1 and Orbita 2, you can see in Orbita 1, they used 3 anti-anginal medications before screening the patient, before randomization. But none of the 3 were metabolic agents. All of the 3 were hemodynamic agents. So they remain symptomatic more than 50% of the patients, despite the fact they had treatment. So this tells us that the optimal medical treatment has to be with a metabolic agent also. And the same thing goes to Orbita 2. I think the metabolic agents were used less than 5% of the patients. So it's another comment about that. And about the question related to the use of tremetazidine in patients with angina, regardless of the severity of coronary obstruction, particularly in microvascular angina, I use it in both ways, in the patients with coronary obstruction, but also with microvascular angina. Every symptomatic patient, I use tremetazidine, despite the fact of the cause. because including in those cases with obstruction, remember that they have sometimes diffuse artery disease in the microvascular area, and they have an obstructive plaque, but they also have vasospasm in the same artery. So sometimes when you use a metabolic agent with an hemodynamic agent, you can relieve from the angina for the patient. And I use it especially they have a special effect on the microvascular angina, because of the substrate of the obstruction is not always relieved by nitrates, neither by the calcium channel blockers, where the beta blockers doesn't have too much of action in the microvascular angina.
Yes. Now we are going towards the end of the symposium. There is one raised hand from Carlo Martinez. If you can make your question quickly, and we'll have a quick answer.
Okay, thank you. Sorry for my camera. I have some problems with the configuration. My question is about the treatment. I have no doubt that the main treatment should be medical therapy first, and second, the interventional therapy. So my question is, how long should we wait in order to go to the second step, that should be the PCIs? I mean, how many anti-anginal drugs should the patient take in order to go to the second step, or how long in time should be the patient with angina in order to go to the second step? I don't know what are your suggestions. Thank you.
Yes. Now, as you know, the guidelines suggest that the use of, as we've heard from our speakers, of combination therapy from the beginning. So if you use that approach, probably if a patient is still symptomatic after 3 months on 2 or 3 more medications, then they should you can consider the angioplasty. If you use a stepwise approach, that will take much longer, because you see the patient once, then you have to wait until you see next time, and then if they are still symptomatic, then you add the other one. So this is why probably the approach, it's of giving the combination therapy from the beginning makes more sense. Now, unfortunately, we got to the end of our meeting. There was one other question from Mauricio Riviera that asked what is the modification of angina in patients who had a coronary intervention. Of course, there is an effect both on the severity and but also on the threshold of chest pain. But sometimes also the quality of the chest pain may change. And sometimes there is another issue, that is they tend to come back with the same symptoms that they used to have before. So I see that there are still people getting into the chart now, and especially commenting on the importance of using revascularization together with medical therapy. So I think, unfortunately, we have to close, but I think we had a very good webinar. It got heated towards the end, so it was good that we had a very good participation. We got insights on the symptoms, on how there's the interaction from patients and healthcare professionals. We had an in-depth view on the cardiac metabolism and why it's important to approach patients with metabolic therapy. And we've had all the news from the new coronary, from what has happened in the past year in terms of chronic coronary syndromes, especially Orbiter 1 and Orbiter 2. So this is the first, there was the first webinar, then there will be a second webinar that will be chaired by Professor Fausto Pinto on the 10th of April, where they will focus on the diagnostic pathways and on treatment profiles in patients with angina. So thank you all for your participation. I wish you a very good rest of your day, and I look forward to seeing you very soon. Goodbye.